Hi, Calgary residents. Thank you very much for your fantastic contribution to the last Dare to Diagnose. You guys did an absolutely awesome job. So I'm just going to quickly recap what the question was. So we have a patient coming in for an amputation with significant comorbidities. We knew that he had a moderate decrease in left ventricular ejection fraction a few years ago. You repeated the scan, and your task was to review the echo and come up with diagnosis and your anesthesia considerations and plan. You were going to look at the echo and tell me about whether the echo was a good enough quality to interpret, and then do a systematic review of all of the aspects of the heart. So what did we think about this parasternal long axis? What is the quality of this image? As you all pointed out, there were some dropout on this wall, but for the most part, this is a reasonable parasternal long. This is really the base of the heart is what we're looking at for the parasternal long. We want to be able to see the atrium, mitral valve, aortic valve, and that outflow tract. To improve the quality of this picture, I could have had a little bit more ascending aorta in here. So if we're going to look at this systematically, what can we say? So the left atrium, and aortic diameters at this in this view should be very similar. So the left atrium probably seems a little bit enlarged here. The other thing that's really obvious to me in this view, and this really jumps out, is how little this mitral valve is moving. If you see that in an image, you really want to manipulate that image a little bit, or those loops, so that you make sure this is just not just an acquisition problem, or image acquisition, that you're cutting the valve at an odd angle. But if this is really truly mitral valve opening, there's something really wrong here. And that's either the mitral valve having pathology, or this patient has a very low flow state, and that's why that mitral valve isn't opening. The rest of the ventricle, we can see a little bit of the base, a little bit of the anteroseptal infralateral here. RV, we can't really say much. And the aortic valve does look nice and clean in some of the views here, and it looks like it's opening well. So our next view was a parasternal short axis. It wasn't a perfect view, although you could get some information from it. And mostly what I'm seeing here is that really only the lateral wall is moving. The rest of this looks pretty dead in the water. Our apicals were up next, and the apicals was a little hard to get the whole heart into the picture. That right base was a bit challenging. On this view, we can really see that very little is moving here, septal, lateral. I did try to zoom in on the apex in some of the views to make sure there was no clot there, because the apex wasn't contracting much either. LA is enlarged, LV is dilated. And then here, now we can see that RV base. So the RV, you always want to see base as well as free wall. This does not look like it's coming up very well visually, confirmed by our TAPSE in the next view. That was only 1.4. 1.6 is the standard for normal. Now we're looking at our subcostal view. So here we have our left atrium, left ventricle, right atrium, right ventricle. We can definitely see our right ventricle very well in the subcostal view. It's very close to us. You can see this free wall is barely doing anything, and the base is very, very much not contracting, consistent with our previous impression of the RV, even though we didn't see it that well in the apical view. Here's the subcostal short axis. A little bit high. We're seeing quite a bit of mitral valve here, so we'd like to have it a bit more apical. But we can see this RV is not working very well. LV function, really quite poor. I'm not really even seeing that lateral wall come in as well, and maybe that's just because we're a bit basal here. That was the lung. So here we have the spine. Remember, your spine, you should only see spine up to the point where you have the diaphragm, because usually there's lung in this area, and because the ultrasound doesn't penetrate air, full tissue, you don't see the spine if there's normal lung here between the probe and the spine. We only see spine here if there is atelectatic lung consolidation or effusion, and this is definitely quite a large pleural effusion. So, this was your follow-up scenario where you were post-op in the recovery room with a hypotensive patient, and this was the IVC view that I gave you, and I asked you for your management plan. And what this IVC view is just showing is sort of, I'd say, at baseline, probably fairly dilated. If you think this is 1 centimeter, it's probably coming up to the 2 centimeter mark, but collapsing. So probably a patient that could tolerate increments of fluid, and you all very correctly stated that you would fluid resuscitate, but in smaller boluses than usual, sort of 250 ml increments, and likely repeat the hemoglobin just to make sure that there wasn't more blood loss than we had thought. Okay, so what was our diagnosis for this dare to diagnose? Correctly diagnosed by everybody, significant biventricular dysfunction with regional wall motion abnormality and a large pleural effusion. So good job, everybody. So what I'm going to do is just sort of plug this into my sort of oral exam and my practice kind of mindset when I think about patients. So when we're looking at patients pre-op, so first I'll look at optimization. So would this patient have required any further optimization? Some of you recommended that potentially we could get hemodialysis involved if we thought that this was a fluid overload issue. If it wasn't an emergency patient, and that is a good suggestion, because you can find in renal failure patient, end-stage renal failure patients, that their hearts can look like that just because they're very fluid overloaded at the time. And probably one of the ways to look at that would just be to track their weight. So that would be one thing you could look at to see if this patient would require a dialysis consult in advance of surgery. The next point in optimization is that you look at what the resuscitation is required with very specific endpoints. That's more relevant to our question in recovery. So a lot of you did say you would give fluids, but for real colleagues purposes, I'll start practicing to say which fluid you'd give and how much. And that just becomes very much a natural way of expressing yourself. You would address any labs that might be abnormal. So for this patient, particularly with the renal failure, we would check the potassium and make sure that that poor cardiac function wasn't due to a high potassium. And we would have blood products available since amps can bleed. Probably just type and screen for this patient, not a cross match. I would do a very solid risk discussion with this patient. And then we would make our anesthesia choice. We would look there at our pros and cons for every anesthetic choice and whether there's any particular surgical considerations, which there really isn't for this patient. We would prepare our OR with whatever drugs and equipment and help that we feel we would need. Intraoperatively, we would decide on our monitoring, so standard CIS, and then you decide what else you would have. We would establish what positioning was needed. We'd pay attention to heating, the patient, the room, fluids, and we would decide if there was any special considerations for emergence. For post-op, we look at disposition. Does this patient require any kind of special disposition? And is there a specific requirement for analgesia, which I think this patient had. So in terms of this anesthesia choice, so all of you decided to do a regional technique, which is fine. I think general anesthesia can be done in a patient like this, but you do need to really think about the weaknesses of that technique and bringing in the right monitoring and the right medications to help you support that patient, especially have some things available for the right ventricle. And you would definitely have to support LV function. Monitors. Do we need a 5-lead ECG? Do we need an art line? And positioning would just be supine, so no special considerations there. What did we do for the anesthetic for this patient? We decided to do a low-dose spinal with the patient on their side, so we did heavy Marcan 1.2 cc's. We also added in some nerve blocks for post-op analgesia and put a stump catheter in. So for us, a big part of our post-op disposition was thinking about post-op analgesia. And intraoperatively, we went for the as little as possible approach. So I hope you find these scenarios helpful. Continue to focus on your focus. See you soon in the OR.